Hello and good morning, good afternoon. Welcome to the SAME Health Engineering Task Force webinar on implementing wastewater surveillance for COVID-19 with Northwest Tribes. I'm Lieutenant BJ Tamang, a Senior Environmental Engineer for the Portland Area Indian Health Service in Spokane, Washington. And it is my pleasure to serve as your moderator for this presentation today. Before we begin, I wanted to recognize the Health Engineering Task Force and the presenters' hard work over the past several weeks. I got a little bit of a peek behind the curtain, and I want to say I'm really impressed by the team's professionalism and the attitude of excellence. So thank you for putting this on. So let's carry forward. And before we begin, today we'll go through a few housekeeping notes and tips, and these are going to make, hopefully, provide a good experience for everyone involved. So for the visual learners, please take a moment and read through them. For the auditory learners, I will go ahead and read them out loud. So those connecting through a VPN will likely have difficulties. If that's the case, please ditch the VPN. And audio is broadcast through your computers. When you have entered, you should have been prompted to connect to the audio stream. Click connect and turn up your volume. Use the chat tab on the control panel to submit a technical issue. Look at the private tab for your response. And as far as the questions go, submit a written question at any time via the Q&A tab. Upload questions that have already been asked to avoid duplication. Another thing it does is also lets us know that, hey, this question is really important. So if we're pressed against time, we can prioritize accordingly. So please do use that button. And additional notes on the question is that we've allocated about 10 to 15 minutes towards the end of the presentation. So when the question comes up, please go ahead and let us know. Just know that we won't have an answer for you until the end. And so click on the handout tab to download a copy of the presentation slides. And finally, this webinar will be recorded for your future viewing. All right. So now, in order to get a better understanding of the audience, we would like to ask the following poll question that you should see on your screen now. Please take a moment and fill that out. All right, looks like we have about roughly a third of the answers. Looks like we're about half now. Okay, so I am seeing 19 responses. Looks like, let's see who the winner is here. So active duty military. Well, thank you everyone again for attending. So let's move this forward here. So before we get into the presentation now, I just want to go quickly through the introduction. Today, the presenters, first of all, it's Captain Weiser. He is the medical epidemiologist for the Portland Area Indian Health Service, assigned to the Northwest Portland Indian Health Board Tribal Epidemiology Center since 2007. Commander Benjamin Chadwick is the District Utility Consultant for the Portland Area Indian Health Service, Division of Sanitation Facilities Construction Program, where he oversees the operation and maintenance program. And finally, the last speaker is Lieutenant Commander Jason Davis. He is a Tribal Utility Consultant for the Portland Area Indian Health Service. He graduated with an environmental engineering degree from the Oregon State University, and he's an enrolled member of the Chickasaw Nation. And all three of these presenters, they represent the Public Health Service. All right, so with that said, that concludes the introduction. I will now turn it over to the presenters. Gentlemen, the floor is yours. Thank you.
Hello, everyone. Thank you, Lieutenant Tamang, for the introductions, and I appreciate it. as he said, I'm Commander Ben Chadwick, and grateful for the opportunity to be able to present to you today on some of the work that we've been doing related to SARS-CoV-2 wastewater surveillance with the Northwest Indian tribes. Just want to take a note real quick that I'll make a note that the information we'll be sharing comes from our work and experiences with the tribes. However, this information is also relevant and can be used for any community that has a wastewater system. For part of my presentation, I'll be using the term COVID or COVID-19 when referring to SARS-CoV-2. So to start, I'd like to go over how wastewater surveillance works. People infected with COVID-19 can shed the genetic material from the virus in human fecal waste, and this can be detected in community wastewater. The wastewater is from a sewer shed is collected as it flows into a treatment plant or some other collection point, which could be a lift station or a manhole. For our purposes, definition for sewer shed is a community area served by the wastewater collection system. Then once we have a sampling point, the samples are taken and sent to the environmental lab for testing. You can also test for other constituents, not just COVID-19. Now there are different actually sampling and testing methods there at the lab, but those will be explained later in the presentation. The health departments receive the testing results once completed, and then they're processed, interpreted, and analyzed. These analyzed testing results can serve as an early warning that COVID is spreading in the community. Once health departments are aware, communities can act to prevent. There we go. Apologize. Once the health departments are aware, the communities can act to prevent the spread of COVID-19. And then once the analyzed testing results are brought together, they can be shared for community education, mitigation measures, and things as such. For those of you who aren't familiar with the Indian Health Service in the Portland area, I just want to give you a brief background on who we are and what we do. The Indian Health Service is an agency within the Department of Health and Human Services and is responsible for providing federal health services to American Indians and Alaska Natives. Our mission is to raise the physical, mental, and social and spiritual health of American Indians and Alaska Natives to the highest level. The Indian Health Service is divided into 12 physical areas within the U.S., and the Portland area is one of them. Each area has a unique group of tribes that they work with on a day-to-day basis. The Portland Area Indian Health Service provides access to health care for an estimated 150,000 American Indians and Alaska Natives residents across the states of Oregon, Washington, and Idaho. The Division of Sanitation Facilities Construction Program is responsible for the delivery of environmental engineering services and sanitation facilities to 43 American Indian communities. The Division of Sanitation Facility Construction Program, which I am part of, provides technical and financial assistance to the tribes for the development and construction of safe water, wastewater, and solid waste facilities, and other related support facilities. For the Portland area, under this program, we have 3 district offices, 2 in Washington, Bremerton, and Spokane, 1 in Portland, Oregon, and 3 field offices for the more remote areas in Port Angeles and Yakima, Washington, and 1 in Fort Hall, Idaho. And of course, Portland area is our area office, or Portland, Oregon is where the area office is located. Just kind of give you a background on how the Portland area, how we got involved. In April of last year, 2021, kind of as the Delta variant was picking up, the Oregon Health Authority, in partnership with Oregon State University, started their COVID wastewater testing and surveillance program. One of the local tribes started participating in the program, and they thought it was beneficial. Portland area leadership, after hearing about this, thought this might be a benefit to the area tribes and supported the endeavor for us to provide assistance to the tribes who were interested in their own wastewater surveillance program. Currently, there are 4 tribes in the Portland area that are actively doing COVID-19 wastewater surveillance with a couple others in discussion about starting testing. Since the Portland area spreads across 3 states, that's can kind of pose some challenges because each state is different in how they approach COVID wastewater surveillance. As an example, the state of Oregon, the Oregon Health Authority, they were one of the first to start moving forward with this about a year ago. And so they're further along than, say, the state of Washington, who is about 6 months ago started with theirs. And then there's the state of Idaho, who hasn't even, that don't even have a program available. Because of this, it required that we coordinate with several different federal and state agencies and educational institutions. A big partner is the Center for Disease Control and Prevention, CDC. As I mentioned, the Oregon Health Authority, as well as Washington State Department of Health and Oregon State University. As of late, it seems like the Oregon State University has kind of taken the lead on that. But the Oregon Health Authority has been providing a platform to show the results. Fortunately, CDC, because the state of Idaho didn't offer that, CDC has offered that opportunity for the tribes, wastewater surveillance, and so for the state of Idaho, and so that has been a benefit to the tribes there. When trying to get the information out to the tribes about COVID wastewater surveillance, we started doing community outreach. Since we had not done something like this before, it was a learning experience. Initially, we sent out emails to just the tribal utilities, but received very little interest. And looking at other ways to get out the information, we prepared and drafted a letter, a tribal letter that was, as well as a one-page summary that talked about what COVID wastewater surveillance is and how it can benefit you. That was sent to all the tribal leaders in the Portland area, and it did generate some additional interest. And then also, when the opportunity, we also provided additional information to tribal health leaders. Those were meetings between our Portland area leadership, and that involves individuals such as Dr. Weiser, who will be presenting later, and the tribal health leaders, which are CEOs of the health service units. And this helped probably generate the most interest for doing wastewater surveillance. And then also, when the opportunity arose to share information about wastewater surveillance at the tribal council meetings. And we found this was also an effective way of gaining interest. One of the things that we found while doing the tribal community outreach is tribal support and buy-in is essential for the proper wastewater surveillance implementation. In order for this to happen, the information provided to the tribes needs to has clear objectives and a defined outcome. We received a lot of questions such as, how will COVID wastewater testing and surveillance benefit the community? What do we do once we have the results? And who is given access to the testing results? And many other questions. And those types of questions need to and probably should be answered prior to any sampling taking place. As an example, one of the tribes we're working with the tribal utility has received the results, and I talked to them just recently, and they were wondering how, what do we do with these results? We don't really understand them. And so it's important that we know who the players are and the participants in this. Also, one of the concerns I heard from the tribes when talking about wastewater surveillance is how much time will it take, especially from the tribal utilities. This is a big concern for them. They're busy and they don't have a lot of time for extra duties. And so they need to know up front what is required of them and the amount of time needed. And that's where it's important, and not just tribal utilities, but also the tribal health leaders and anyone else involved. It's important to try to minimize the time burdens. Also, when we first started contacting the tribes to determine their interest in implementing COVID wastewater surveillance, there weren't a lot of resources available to share with the tribes. However, this is somewhat changed, and it's important to provide the necessary resources so all parties involved can make informed decisions. Particularly depending on where the tribe is located, it seemed like each state had different different ways, different standard operating procedures. And so it was important that this information was relayed to them prior to making those decisions. And one of the biggest challenges for us was getting support from all involved parties, particularly at the tribal level. We found that it was extremely important to have a collective coordination between the tribal health leaders and the tribal utilities. Everyone needs to be on the same page. I'd like to share an example of that. When one of the tribes, when this first started about a year ago, the tribal utility took it on themselves. The opportunity arose to do wastewater surveillance, and they moved forward with that, and with good results. And so when the time was up and it was time to renew, they wanted to bring on the tribal health leaders, and they weren't interested. And so it kind of made it so, what do we do now? And that's why it is very important, and not just between the tribal health leaders and tribal utilities, is needed for an effective and sustainable wastewater surveillance program. All parties, basically, this coordination needs to happen between all of them. And vice versa, I've seen it where the tribal health leaders have been interested and the tribal utilities aren't. And so there needs to be that partnership. That is it for me, and I'm going to turn the time over now to Lieutenant Commander Davis.
Thank you, sir. Good morning, everyone. So, and Commander Chadwick is correct. The challenge initially is the coordination between all parties. Typically, operators who we have been contacted by initially for a tribe to be engaged and involved in the wastewater surveillance. Now, having engagement by public health professionals within the tribes, it's been key and important by the state health departments and probably with the CDC to have a full involvement by those who would not only be doing the testing but interpreting the results, which is key, which is that's the end goal. So, but going back to the operators and the actual testing and sampling piece, CDC has developed, there's a national wastewater surveillance system that CDC has developed. There's tons of information on their website. Screenshot here. The link is down below. You could easily find it through a web search. It, again, is tons of information there. We have kind of used that to help guide the tribes. But mostly with the testing and sampling is coordination with the states. And as you'll see, there's different testing methods, which also require a different kind of sampling. And in Oregon and Washington, the state health departments are spearheading the efforts. State of Idaho, I believe, does not have something in place at this time. I know that CDC has a third-party contract out with two of the tribes. They are actively doing testing, and they are working with CDC through a third-party national contract. So sampling and equipment. So again, there's a sampling method or a plan that each tribe will use, and that is dependent on the testing methods. We're currently working with 2 tribes in Oregon. We're hoping to get more involved up in Washington and in Oregon as well. But given that, what we're aware of at this point are 3 different methods that will be used and are being used for the testing, so which then impacts the way the samples are collected. In Oregon, it's a over time collection, 24-hour period over time where the samples are taken. There's a composite sampler that takes samples every 15 minutes at a wastewater treatment plant, and the same would also be the case. We have another collection being conducted at a lagoon system in a manhole. And I'll have pictures of those you can see here in a minute. But that particular sampling technique over a 24-hour period is, with Oregon, is used as a well-mixed sample of that full collection is run through a filter. It's roughly about 30 mils a sample of the effluent run through a filter. That filter is then collected and placed in a solution for shipping off in Oregon to Oregon State for testing. There's a redundancy, so there's two that is conducted twice per 24-hour period for redundancy. And those results are typically turned around within a week. That data is back to the tribe. We haven't worked directly with any of the tribes from Washington, but we've had plenty of discussion, and I know that they use a 500 mil sample, which is a much larger sample. It is collected over time as well, and that full sample is actually shipped off to their testing lab for results. And interesting enough, the Idaho tribes are working with a national contract with CDC, actually have their wastewater tested via grab samples that are taken periodically. So fairly different approaches for the samples to be tested. Equipment used is likely to be something any wastewater plant is going to have in place. This composite sampler, there's a picture here on the right of one that's being used now. There's also a portable one that's used for remote or, like I mentioned, a lagoon system. It's placed in a manhole, which also has its own power supply, so it's a battery pack. There are different manufacturers of this equipment. And the one thing we did run into initially, given there was kind of a spike in demand once this was being rolled out, the COVID wastewater testing was a definite lead time, several weeks out, which we had to plan for. So procurement of equipment that was needed, it took about 2 months once we had all our paperwork in place and funding identified. So again, this is a composite sampler. This container is actually refrigerated, so that sample that's collected has to be kept refrigerated and maintained at 40 degrees prior to filtering in Oregon. And again, I believe in Washington, that temperature has to be maintained through the entire shipping process. So it has to be packed in a insulated container that is also dry ice, or I'm not sure what can be used. I don't believe there is I believe there's a minimum temperature that you need to maintain. You definitely don't want to freeze the sample, but I'm not sure that there is a concern about, dropping down to 20 or 10 degrees Fahrenheit. And again, for the sampling itself, in Oregon State University, who is working in conjunction with the Oregon Department of Health, provides the sample kits to the tribes, which is something that they have to ensure that they have on hand, and as they get low, give enough lead time that prior to the sampling being done, that they have plenty of those kits on hand. So again, as I pointed out, there are multiple sampling methods by the tribes here. Kind of reiterating the 40 degrees Fahrenheit requirement. And also the shipping needs to be done within 24 hours of collection or preparation. And that's pretty key. You want to make sure that the samples are tracked, with tracking information. I think that's pretty standard. Just looking through here. And again, this is kind of a reiteration, but again, there's the different sampling methods, which are basically dependent on the testing methods. Now, I know that Oregon State actually developed their own testing method, or at least was heavily involved in. I don't have the details on the specific tests run, but it is interesting how vastly different it impacts how the samples are collected and the volume of sample shipped off for testing. So again, Oregon Health Authority and Oregon State University are working closely together. CDC is contracted with a national entity or a national contract the entity is providing, and I believe it's throughout the nation. They're providing the testing and the sampling. And Washington State Department of Health is also working with the University of Washington. So it's definitely a collaborative effort, multiple parties involved. Again, as Indian Health Service, who we're with, we definitely work with the tribes. But I know that there are various municipalities that are also engaged in collecting their own samples. So it's definitely a multi-pronged effort. And here, as you can see, there's some more. Let me back up one here. This is just a picture. This is in the Oregon sample. I don't know how well you can see that picture, but that's just a picture of the sample being run through a filter and to be sent off for testing here in Oregon. Again, there's more pictures. That's the Composite Sampler for in-place sampling at a wastewater treatment facility. These two pictures here are a portable composite sampler that's actually lowered into a manhole for collection. One thing is, at least the tribe here was concerned in making sure that the equipment was secure and not open or vulnerable to, theft or vandalism. It's definitely a concern. They wanted to make sure that they kept tabs on. And there's one other thing that has recently come out is that there's been a request to provide flow data to accompany the samples, which is to help normalize, I think, the results. That flow data is kind of important to help dictate, how much we've got the sample, but then how much volume is that sample being taken from? And again, these samples should also be representative of a specific community or tied back to a specific area, which for any treatment facility should not be an issue. But again, you want to know the area that's being represented for each sample. But that was an interesting thing I wanted to point out too. I didn't have it in my notes here, but in the presentation, but the flow rate is an important piece of data that actually accompanies each of the samples as they're shipped off for testing. At this point, I'm going to hand it off to Dr. Weiser. It's all yours, sir.
Great. Thank you, Lieutenant Commander Davis. Really appreciate all the background that you guys have provided and all the work you guys have been doing on this. I'm going to go over some of the public health uses of wastewater surveillance, and then I'll share with you some of the data that we've collected from one of our sites and kind of build on some of the things that have already been mentioned in the previous part of the presentation. So using data from a pooled community sample can provide information about COVID-19 transmission or prevalence in communities, especially where timely COVID-19 clinical testing is either underutilized or unavailable. And this was the case for some of the clinics during the recent Omicron surge in our area, where testing demand outstripped our capacity to provide that kind of clinical testing. Ongoing monitoring can provide information on emergence or reemergence of infections within a community prior to case reporting, and is not affected by certain limitations of clinical indicators, such as variability in healthcare seeking behaviors. So we notice that when cases begin to to happen in a community, it drives people to come in and get tested more. And then when cases are slacking off, then fewer people come in to get tested. And that's where that variability in clinical testing really hampers our ability to know what's actually going on. So other uses include tracking trends in specific communities and screening for new infections at the building or facility level, such as in schools or corrections facilities. SARS-CoV-2 wastewater surveillance data can potentially be used to inform clinical testing and community mitigation strategies, such as when to increase testing of individuals in an affected community, or how to tailor or increase public health communication about how individuals can protect themselves from COVID-19. And another example would be to monitor the impact of community mitigation strategies. So on this slide, I'm showing the relative wastewater testing and clinical testing scales. So how do we interpret this information? What does it mean? So on the left side is the clinical percent positivity, and on the left side is the wastewater testing values, and on the right side is the clinical positivity testing. And you can see that for the wastewater testing, there is a limit below detection, so less than 5.75, and this is normalized values, the log of copies of the virus RNA per day per person. So if it's below that certain level, we can't really say anything about those readings. And then there's a low, a moderate, strong, and very strong readings that come from the wastewater testing. And on the right-hand side is the clinical positivity. So we've been monitoring this since the very beginning, and this is based on the total number of clinical samples taken and the number that are positive. We calculate the percent positive, and we have indicated levels for low transmission, moderate transmission, substantial, and high. So this is a graph here of our actual data. It's the wastewater testing data from one of our tribal communities, and that's shown by the blue bars. And again, it's the log of copies of viral RNA per day per person. And that ranges on the left vertical axis from 5 to 9. And then there's a white dotted line along the bottom of the graph there. And that is that limit of detection. So below 5.75, we wouldn't be able to make any conclusions about that sample. But all of the samples that we collected were well above that limit of detection. And then the orange line with the black dots is our clinical specimens. So this is the average percent positive over the previous 7 days. And that's from the one IHS clinic that serves this community. And the values there are shown on the right vertical axis, and those values are ranging from 0 to 35%. So I'll just walk you through this data, and I've added in there the different sort of variants and when they were happening in our region during these times. So at the beginning of the graph, in mid-August, the wastewater values were moderate. So the value was 7.2. But in the second week, they increased to the strong level, 8.3. And this was 2 to 3 weeks before there was any rise in the clinical testing, that orange line. So this was during the early Delta period, and that's shown on the bottom there. Both the clinical testing and the wastewater testing fluctuated throughout the next 2 months during the Delta predominant period. The peak during this time was in the second week of October for both of the measures. And the wastewater values were in the strong range for most of the Delta period, as you can see on the graph. In December, while clinical positivity gradually decreased from wastewater testing values increased again. And this time they reached above 8.0 by the end of December. And this was as the Omicron surge was beginning. Again, the rise in wastewater values preceded the rise in clinical testing by about 2 to 3 weeks. We have to point out there is 1 week of missing data from the holiday week, and that's shown by those 2 yellow lines there. So the decline during the end of the Omicron surge can be seen in both wastewater values and the percent of clinical specimens testing positive. And both of those gradually were going down just really at the same time. And as of March 1st, both were still measuring in the moderate level, but since then they've both gone into the lower range. So to summarize, wastewater surveillance is a valuable tool that can be used for infectious disease surveillance at the community level. The information can provide an advanced signal of changes in community transmission. In the case I reviewed, about 2 to 3 weeks before there was a rise in clinical testing, we see an increase in the wastewater testing. It was particularly useful to monitor and track changes in community transmission over time in remote communities where access to clinical testing might change over time. And to recap some of the earlier points, when working with tribes, successful deployment requires close coordination with tribal leaders and with all those involved in the project. And the final note is sensitivity regarding data ownership and use of that data is critical to foster trust between tribes and government at all levels. One thing we didn't mention was the data sharing agreements and the agreements between tribes and CDC or the state health departments that were sponsoring this testing. I'd like to just acknowledge the Northwest tribal leaders that have participated in this testing program. We really appreciate their forward thinking and engagement in this, and particularly Chico Holiday, who is with the Confederated Tribes of Warm Springs Wastewater Operations, who collected the samples that were in the data that we showed. Casey Canales from Oregon State University facilitated the analysis of those samples and reported the results back. Dr. Eitan Bornstein, who's our Epidemic Intelligence Service Officer from CDC, assigned to the Northwest Portland Area Indian Health Board, and Mr. Dean Saylor, our recently retired Portland Area IHS Director. So with that, I think we'll move to the question and answer and provide any other feedback.
All right, thank you, sir. Gentlemen, excellent presentations. Like you said, we do have a few questions. If you're ready, I will roll right into that. So there's a question from Mr. Ramji Raghavan about why there are different sampling methods.
So I'll tackle that one. I don't know that I can necessarily say for certain why there are different sampling methods. I know that the states have established their own testing, which dictates how the sampling occurs. And in the case of the national contract with CDC, I believe it's the same. I've had questions about the differences in the sampling and testing. I should point out wastewater surveillance is not necessarily a new activity that's conducted. It's definitely used for beyond COVID. There are a variety of I guess chemicals or constituents that wastewater can be tested for. So this has been something that's been ongoing. As far as the positivity rate and if there's a difference in the sampling methods, not that I'm aware there's any difference. I'm sure there is some. But again, as Dr. Weiser was pointing out at the end of his presentation as well, we've certainly got the data to show that it's a much the wastewater sampling is a leading indicator of a possible peak or spike in COVID cases much more quickly than individual testing. So I'm not sure if I fully addressed your question. Do my best again, the difference in the sampling methods, definitely based on the testing and the lab work.
Yeah, I'll just add that we worked with different jurisdictions, and each of those jurisdictions were in control of how they were doing the testing. And so they set up the parameters for how the tests would be collected. And we just followed their guidance in order to be able to provide the samples and get the testing done. And really the one community I showed the data for is the one that we've looked at closest. We haven't gotten the data back in a usable format that we can do the similar thing for the other communities yet. But that's our goal. We're still in the beginning phases of implementing this as a surveillance system. So it'll be interesting to see if there are any differences with the different sampling methods that we have.
Okay, thank you. So the next question is from Anna Marotra. You mentioned the importance of minimizing the time burden on tribal utilities. What steps did IHS, Washington State Department of Health, the third-party contractor, and/or OHA take to that end? Approximately how many hands-on time is required of the utility staff per week for each of the sampling methods?
Okay, I will answer that one. So one of the things I had mentioned of being, with the time burden, but also providing the tribes adequate information. If you provide them the resources so they know and they can prepare for that. One of the things that with the department, with Oregon State University and the Department of Health for Washington, and for even the third-party contractors that are hired by CDC, they're providing the bottles. So basically, they're providing the bottles to the tribe. Also, they're providing the packages to ship the bottles. And so they have it all set up where hopefully it's minimal time where the operator can then do the sampling, drop it in the package, and just drop it off in the mail. So that actually has helped reduce the time, with them not having to worry about collecting the sampling bottles, as well as, trying to worry about shipping them and what containers and all that. Now, with regards to time taken, it really depends on the sampling method. So with Warm Springs as the one that we're using as an example with the data that we had, they sample over a 24-hour period. Typically, they start on a Monday and they end on Tuesday. Now, granted, they don't have to sit there the entire time, but they do get it started. Then they gather the results, and then with that sample as well, then they also filter it. So that one actually involves a little bit more time. The grab samples, typically that is done more often. I know, at least talking to some of the tribes in Idaho that are currently doing it with the third-party contractor, they sample twice a week, Tuesdays and Thursdays. And again, that's just a grab sample. So they fill a 500 milliliter bottle, and then the container's there to ship it. And so, again, it varies with time. It could be anywhere from a couple hours. To maybe half a day total per week, 4 hours a week. So, do you have anything else to add, Commander Davis?
I guess the only thing I might add as far as time-wise, I know, for example, in Confederated Tribes of Warm Springs Reservation, there's some travel time involved in getting out to there's the lagoon site that's used. But again, that's typically, I think, no more than a morning, 4 hours probably. That's a definite concern, though. Often in our tribal communities, operators, so there's a lot asked of them. Time is kind of a premium, so it's not necessarily something that we take for granted that they're going to have time to add this to their normal day and routine. And typically, they're spending a lot of time addressing and dealing with issues. But so far, it's not been an issue. And they've been very successful in grabbing the samples.
Okay, thank you, Commander Chadwick and Lieutenant Commander Davis. The next question, we do have a little bit of time, so I'm going to stack two questions from Mr. John Anderson together. First question is, any difference in the positivity rate depending on the sampling method used? And the second, somewhat related, might be, how does a sample positivity rate translate to a population positivity rate, if at all? And I can repeat the questions again if you'd like me to.
Yeah, I think I can try to answer these. The first question about the different sampling methods, I don't know if the others have seen that data, those data results come back yet, but I've not seen those. The only community I've seen the data come from is the one that I showed. So we only have that one method to discuss. And if you think back, and I don't know if we can go back to the slides, but the slide that shows the two different scales, that's basically how we're translating this. So the population positivity rate, it's really the burden of RNA virus per person per day that is being measured in the wastewater. And so those different gradations of high, medium, and low, and non-detectable are what we're using. And they are normalized for the flow. And so that's how they're able to get that copies of virus per person per day. And so that should translate to the burden of COVID in that community.
Thank you, sir. Okay, so next question is from Mr. Ramji Raghavan. So a fragment of the question that I have here is, one, is sampling automatic or manually done? Second one is, does this mean you don't have to do COVID testing? So maybe we need a little bit more of a context over there.
First question to Commander Davis.
Yep.
So for the automated sampling, in the case of the 24-hour collection period, there's a composite sampler, it's on a timer, and that is automated. I believe it has to be manually turned on and off, and that's specifically to the tribe in Oregon here that I'm talking about. I hesitate to say that 100% that it can be, but I'm pretty sure that can be an automated process where you could have the collection period automated for the composite sampler to turn on at a certain time and then turn off, at a certain time. So in that respect, yes, it could be automated. I know the grab samples, I don't believe are automated, and those are conducted just manually. And also for the large samples, again, I believe that's done manually.
And I'll take that second question about whether or not we have to still do COVID testing. And the answer is that we're still going to be doing clinical testing for patients who have been exposed, patients who come in with symptoms. We're still going to have that activity. But there's this variability in how often people come in for that kind of testing. And that's where we have a blind spot. We saw that, when testing positivity was low, part of that is because not very many people were coming in for testing. And during that same time, COVID wastewater testing was actually on the rise, both at the beginning of the Delta period and at the beginning of the Omicron. So this fills in a sort of a blind spot that we have based if we're just looking at clinical testing. And that's why it's really important to be able to have this, and especially ongoing, because I'll give an example from one of our tribes. They've been doing surveillance testing by swabbing folks, their noses every week. We've had the National Guard and a bunch of other people out there helping them. A very labor-intensive effort to get a large number of people sampled every week and see that positivity. This is done by a single wastewater operator sending a single sample or a couple of samples a week. And it probably doesn't take very much time at all compared to trying to get 200 people tested every week. So this is a huge time saver for the clinical staff, and especially when you don't have enough clinical staff to do all the work that you need to do for the community.
Thank you, sir. It looks like we have one last question, and that is from Mr. Praveen Gopal Lawa. Did you consider normalizing the data using commonly found pathogens in wastewater?
I think they do. This is a question really more for the people doing the testing itself. And it might be different in the different sampling methods. For example, in Washington, where they send the whole 500 milliliters, then they could perhaps do that. But the data we're getting back from Oregon is normalized, and that's how for the flow rate, and that's how they're getting that amount. Like, I don't know exactly the answer to that question, but I suspect that in the different areas they're doing different methods, that they are normalizing for those different sort of indicators of fecal waste in the sample.
Great. Well, thank you, sir.
Dan or Jason, do you have any more insight on that?
No, I don't, as far as a comparison or some kind of a normalization or a baseline. I believe that's taken into account in the development of the sample method and the testing methods, but that is definitely a question more for the testing lab.
I do know that with in speaking with one of the tribes that are doing in Idaho, that they actually, before a trend can be set up, they have to go 4 samples, and and that's with that particular, the third party, the lab that they're using, and so to set up that trend. So I guess it does, like Dr. Weiser said, and it varies in the laboratories.
Okay, so we're doing well on time, and I don't see any more questions. So great questions, everybody. Presenters, thank you. Great, excellent presentations. I would like to say that, me personally, I'm proud to be associated with gentlemen like you, and part of the USPHS as well as a SAME member. I appreciate all the great work you're doing. I've been privy to some of the information behind the scenes, so thank you very much. And again, I want to thank the presenters, the Health Engineering Task Force, for putting together this excellent webinar. I know there was a lot of effort that went to it for a few weeks, and for providing this opportunity to really develop and grow as an organization. So thank you very much. I apologize if we didn't get to all of the questions, or if you have more questions after we end the presentation, I'll go ahead and include the contact information for the presenters. There you go. There's a slide as well. Mm-hmm. I'll go ahead and put Commander Chadwick's information there also. You're trying to
it's okay.
kind of funnel some questions, not elsewhere. So please, we appreciate you coming here, and we hope there was some value added in your knowledge. So thank you very much.
Thank you.
Thank you, everyone.
Mm-hmm.